So we're here to talk about skin disease and recognizing it in its management. My name is Jeff Callen. I'm a dermatologist here in Louisville. That's where I live and work, and I've been here about 41 years now. My interest in dermatomyositis started when I was just ending my internal medicine residency before I went into dermatology. And I started by working with a rheumatologist at the University of Michigan and studying patients who had dermatomyositis versus polymyositis and looking at the rates of the occurrence of malignancy in those patients. And subsequently, I've written quite a bit about Myositis Association with dermatomyositis. Actually, if you were in the other room, Dr. Mammon put up the Hill study that he was talking about, and it's one of the landmark studies. It was in the Lancet relating dermatomyositis to malignancy, and I was actually one of the, I was given that study to review, and then I wrote an editorial that accompanied that. So if you look back in that old Lancet, I had some commentary that went with that. I focus my practice on treating patients who have complex dermatologic disease that overlaps internal medicine, and so I frequently send patients who have dermatomyositis or diagnose them. I actually was working until I came down here and got here about 3 o'clock just before the lecture started. And today, during my practice, I saw 3 of my patients who were chronic, not new patients, but chronic patients who were treating for dermatomyositis. So I'm relatively fairly familiar with it. You're going to hear from one of my mentees, Ruth Ann Vloigels, over the course of the meeting. She's on the current advisory board, and she comes in here tomorrow, I think, and she has maybe 3 sessions, and she's on the panel on Saturday as well. So there's a handout, so if anyone didn't get it, we have one. We have some more of them up here, but these are topics for us to discuss, and I'm happy to discuss anything that you want to discuss, or questions that I can respond to as you see fit. I decided that I wasn't going to give a lecture, and I wasn't going to show a lot of slides. You know, I mean, if you have dermatomyositis, you know what your skin looks like. You may know the difficulties that you had in first getting a diagnosis. Sometimes it's really evident, and people don't have any problem making it. But my guess is that there probably is more than one of you in the room who might have been diagnosed before that they had lupus before they were eventually diagnosed as dermatomyositis. Is that true? Anybody want to hear that? Yeah, and it's really a difficult. It's a difficult area for many physicians. The rashes look similar, and on biopsy, if a dermatologist does a biopsy of your skin, the skin biopsy looks identical when you have lupus and dermatomyositis. Essentially identical, can't be separated easily. So that it becomes a matter of looking at the pattern of the skin disease and the intensity of itching. In general, patients who have lupus don't have a lot of itching, and patients who have dermatomyositis tend to have, at least in my experience, my patients complain about the itch, and even when their rash is gone, they still sometimes complain about the itch. I see a lot of heads nodding, and that would be one of the worst parts of the itch, I think, is the scalp. Is that true for those of you? Yeah. Yeah, and even after you're under good control with a variety of medicines, whether no matter which of the medicines there are, the itching seems to remain. And if we take off the medicines, it probably does get a bit worse. But sometimes your doctor won't be able to see much, and yet the itching will still be present. You want to go ahead? I'm
sorry. Is the itching caused by what medicines is causing itching, like Tylenol and that?
No, well, okay. So we'll come to that. So I don't mind anybody asking and interrupting questions, but I'm just going to. No, I don't mind it at all. You know, let's take that. So itching is part of the diagnosis, part of dermatomyositis. It is not, there are medicine, if you look at the physician's desk reference, I don't even know if they print that anymore, but it's an old book which had all the drugs in it. But if you look in, these days we do everything electronically. If you look at Hippocrates, which is an electronic version of the physician's desk reference, and you look up almost any medication, they say rash and itch as a side effect of almost any medicine. So that's next to worthless. It all comes from trials that have been done. But dermatomyositis is a disease that in and of itself causes itching. But even when the rash looks like it's gone, itching sometimes remains, meaning that there's probably still inflammation that is present. Okay. Then you brought up the issue of plaque. That's another way that I use to sort out whether or not a patient has lupus versus dermatomyositis. So has anybody in the room had a rash from plaquenil, otherwise known as hydroxychloroquine?
That's how I found you, actually. You wouldn't remember me, but I saw you 10 years ago because I'm a physician and I found the article that looked just like me on plaquenil written by Dr. Jeffrey Callen, so I came and saw you. So I was one of those people that responded poorly to it.
Yeah, so there are patients, so one of the papers that I did write was the use of plaquenil in patients who had dermatomyositis, and when we first used it, we had a number of patients who actually, their skin did respond. But what I found in my practice over the last 40 years is that about maybe 1 out of 5 patients who are treated with plaquenil, and they're treated with it because they have a skin rash. Plaquenil, that's a trade name, so it's called hydroxychloroquine. It's a generic name for those of you who may see it that way, using it either way. But I found that about 1 out of 5 patients who were given that drug who had dermatomyositis would develop a rash. And it's not the rash of dermatomyositis, it's a drug reaction. And what we did in the study that you're mentioning is to compare an age and sex matched group of patients who had lupus and were given hydroxychloroquine to those who had dermatomyositis. And we found a statistically significant difference between the patients who had lupus and dermatomyositis. So very few patients with lupus will develop a rash from plaquenil, whereas patients with dermatomyositis, 1 out of 5, 1 out of 4 of them will develop a rash. Now, on the other hand, if somebody is suggesting to you, well, you have skin disease, you haven't ever had plaquenil, you still have skin disease left after your muscle disease or other processes have been treated, you have an 80% chance of not having a rash and having some benefit from plaquenil. So the rash it can be miserable for a short period of time. It is most often not a serious rash. In other words, there are some drug reactions on the skin that are life-threatening. The rash that's associated with plaquenil is not one of those that is a life-threatening rash. So if somebody suggests to you, well, maybe we should treat your skin with plaquenil at this point in time because they want to use that as an adjunctive therapy, it's not unreasonable to at least consider trying. It's not it isn't generally the first thing that I reach for in my toolbox for treating patients. Okay? Is that clear? Yes?
Yeah, I was just going to say that I started plaquenil 2 months ago, and last night.
No, if you don't have a rash from plaquenil, you're not going to have it. It occurs within the first 2 weeks.
The only rash I got was like a rash on my chest that I've had since I started.
Yeah, probably not related to plaquenil. I mean, I'm not diagnosing you.
No.
But in general, the rash that we see with plaquenil occurs within the first week to 2 weeks of therapy. Was that true in your instance?
Because I was like, except for the person whose eyes were blacked out and photographed, I was, the story was like, I don't know, it might happen between week 2 and 3, and I was beet red from my scalp to under my brow line, and it was incredibly itching. And I was already on 40 milligrams a day of prednisone and methotrexate. They bumped me up to 50 and it did nothing. And then I was, I found the article and I, basically told him, he didn't believe me. He thought I was just in the sun too much. And I had already tinted my car and I was, walking as quickly as I could with my little
Okay, causation, okay, yeah, that is, it should be most of the standard literature, and even the literature, I think I've written something for this group at one point. I can't remember, I think it was Reed, Anne Reed, who's I think going to be here. I think she put together a little booklet for patients. And
I don't think the doctors in Texas have read that yet.
I can't say anything about other places. Yes.
My question is, how prevalent is plaquenil toxicity? I now have retinal detachment.
Okay, yeah. Retinal detachment, that's not the issue. The retinal problem, that is an issue. So that's a very good question. So what, and I'll give you my approach, which is, let's see, if you read the package insert for plaquenil or hydroxychloroquine, it will say that you should have your eyes examined. I think it still says every 3 months. Way overkill. In general, what I do is I will have patients get their eyes examined. I will have them, okay, if they're going to go on plaquenil, I don't have them have their eyes examined until after they've been on it for 2-3 months at a minimum. For 2 reasons. One, I want to know that they're not having any problem with it, it's more acute and they're not going to take it. And 2, I want to see if it's going to work and if we're going to continue it. Because 2 or 3 months is not going to cause any retinal damage. That's the major problem with plaquenil.
6 weeks, I had retinal damage that was confirmed by a retinal study.
Yeah, it's hard to believe that that's actually related to hydroxychloroquine. If it's a retinal detachment, that is different. Is that what you said? Yeah.
Yes.
So the problem with plaquenil is chronic, and it's an effect on the central vision, and you can become blind with plaquenil. But the chance of that happening is very, very low, and the chance of that happening within 5 years is very low. So the latest guidelines from the American Academy of Ophthalmology suggest that people have a baseline examination, which to me would be within the first 2 to 3 months, and then not have another examination until 5 years, because the rate is so low that and retinal detachment is not considered a toxic effect of plaquenil, but there is retinal change that can be seen. And visual fields are one of the things that they test. Sometimes people do some other tests of the eye function that are electrophysiologic tests and fancier tests, but visual fields are what most people do. Now, what I tell my patients to do is to have the baseline and then have it annually. I do that for a reason, because I don't know what's going to happen in 5 years. To my electronic record, it may change. To the current electronic record I have would remind me. I could put in a note and say 5 years from now, this patient should have their eyes examined. I'm too fearful that when I'm continuing to prescribe plaquenil, I'm going to forget that 5 years. So I do it annually. That may be overkill. Have I seen retinal effects of plaquenil? The answer is yes, but not detachments, and it's not acute, it's chronic. More than plaquenil, there's a related drug called chloroquine. That was the one that was first on the market. And hydroxychloroquine is plaquenil. Chloroquine is something called heroin. That is probably a little more retinal toxic than is plaquenil. There's a third antimalarial, which I tend not to use, and I'll explain why in a minute. It's called quinine. It used to be on the market. It's no longer, it's available. It can be mixed and compounded by compounding pharmacies. There are several reasons. One, it's not generally covered by many insurers because it has no human use at this point in time. And 2, it's not like using things off-label. I use off-label things every day. I mean, I'm not sure that there's, other than steroids, I'm not sure there's anything that is specifically approved for dermatomyositis. Okay? I mean, all the things that you mentioned, Cellcept, mycophenolate, which is the generic name, Azathioprine, none of those they're approved for other uses. And we use medications off-label. It's perfectly acceptable medical practice all the time. But I don't use medicines that aren't approved for human use. That's my stance on it. it was approved in the past for human use. But without it being approved for any human use, it makes me concerned. Now, that drug, quinacrine, when it was used in the past, has no toxicity for the eyes. And so people who use, and I used to use it when it was available, in combination with either hydroxychloroquine or chloroquine to treat skin disease. But I gave up using it basically because of the difficulty getting it, the fact that there's no human use in it these days for it, and you know that's the reason. So it's but it's an adjunctive therapy, and it's not a home run. There are few home runs that we have, unfortunately, and there are some that will come along. Yes, ma'am.
I have had this strange theory for a while. I wondered if it had ever come up with you or your patients. You were talking about itch earlier, and just for what I know, being a physician too, that itch is a form of pain and neurological manifestation. So when I was being really nerdy, as I often am, and I was looking at a dermatome chart, and for those of you who don't know what if you've ever had shingles, you know, that usually hits like one part of your skin that's basically the segment where the nerve goes on your spinal cord and it just stays there. But when I looked at the dermatome for where my specific like I've never had anything below my waist. My feet, my legs have never been, and it's always been, and my scalp is terribly itchy until I'm on IVIG. My question is, everything seems to be very pattern specific, symmetrical in certain very specific dermatomes. And I wondered, and then somebody, for reasons that have nothing to do with dermatomyositis, I ended up seeing a chiropractor, which is a long story, but, and like they often say, you know, there's some cervical spine issue thing, which I was a little suspicious of, but it just made me wonder if anybody, and I've never really seen anything written about that, if there's any kind of central or spinal system involvement that would explain the distribution.
I don't think so, actually. I mean, I don't look at the disease as being dermatomal in its distribution. I would not. Yeah, I mean, it is symmetrical. It is usually symmetrical. The rash is commonly on the backs of the hands, and he talked about Gotran's papules. We see changes around the nail folds. That's another. Somebody asked. We were talking a little earlier about the separation of lupus from dermatomyositis. There's some redness and some dilated blood vessels around the nail folds in lupus, but in dermatomyositis you often get overgrowth of the cuticles, and so and people want to push it back, but the cuticles look ragged and they have little hemorrhagic breakdown in them. And when I see that, and somebody was said to have a rash of lupus because they had redness on their arms, and I see that those cuticles. That type of cuticle change occurs in dermatomyositis, and it occurs in scleroderma, which is it's another collagen vascular disease. I don't know that it's really related directly to dermatomyositis, but when I see those changes, it sways me toward dermatomyositis. The other thing that we see in dermatomyositis is something called a Holster sign. You didn't talk about that, but that is where you have, where holsters are worn on the hips. And now I guess there are people who wear a holster. I don't carry it. Maybe we have people who are NIRA members in here. I don't know about it. But there are other holsters. But the holster sign is when you have the same type of rash that you get on the chest and the upper back. Chest, it's called the V of the chest because it's like that V shape. And the upper back, it's called the shawl sign. This holster sign looks identical to that rash, and yet it isn't in a photo. Most people don't have that area exposed to the sunlight a lot. And so it's kind of strange that it's there, and it's sort of typical. It is symmetrical, but again, I don't see it as being in a dermatome, which is the nerve, which is basically nerve.
Not one dermatome.
Yes.
Because I have on, most people get, I have this on here, but this.
Yeah. But that's okay. Now that's the distribution. Lupus and dermatomyositis, same type of distribution, which is generally exacerbated by sunlight. If you were listening in there, Manon was talking about how there is some epidemiologic studies that suggest that if you live closer to the equator, that there's more risk of having dermatomyositis. and that is probably related to ultraviolet light exposure. And so when there are, and then you were saying about going out and being covered up, I think, right? There was, somebody said that.
Yeah, well, I have my card on.
Yeah. So the ultraviolet light, so with lupus, we know, we have been able, not me personally, but dermatologists in Europe have been able to reproduce the rash of lupus with ultraviolet light given experimentally on the back. In dermatomyositis, they've tried to do it, and they haven't been able to reproduce the lesions of dermatomyositis. However, we know when we see patients that if they get sun exposure, their skin disease gets worse. In addition, some of those patients who get sun exposure, their muscle disease gets worse. So that can trigger also a flare of the muscle disease, even if the skin doesn't get worse at the same time, if you have dermatomyositis. So protecting yourself from sunlight, and the best way to do it is with altering when you go out, wearing clothing that covers you, hats with brims that go all the way around instead of just a baseball cap. Baseball caps are better than nothing, but a hat with a brim that makes, I started wearing my Tilly cap, I don't know, the last 3-4 years or so when I go out, because I'm becoming a long distance walker instead of a runner. In the past I was a runner. My knees won't take it anymore, but so I got a Tilly cap and I came home and my wife says, "Oh, Jesus, you look like an old man." I said, "Well, I am, I am." So it fits, but it is. If you don't have one of those, consider it. It's made in Canada. I don't have any. I don't even know. Maybe there is a company that makes it. I don't have any stock in the company that makes those hats, but I have one here. We have. My kids live in California. I have one out there, so I can, when they go out and walk out there, I can wear it as well. And look kind of dumb, but it's good. Yeah.
Now, when you say exposure to the sun, has there been any studies on specifically does that mean? Like, if you're outside for 15 minutes with your shirt off, is that too much, or is it getting to the point of suntan? Because right now,
Okay, so
I go out with a long sleeve shirt, a hat, tan lotion on.
Good.
Almost paranoid.
Yeah, good. Yeah, so how much sun? It's not clear. It varies from one individual to the next, and I have a patient who, we have these large windows in our office, and I can see out, so I would see him, and then he leaves the office, he gets into his convertible with no hat on, and he's shaved his head, and he drives downtown. And one day I was going also downtown, I had a meeting down here. Our office is about 9 miles outside the city here, and I'm following him on the highway. I see him right in front of me, and he's got his, I'm talking to him about sun protection. Well, the thing about it is he actually doesn't seem to be photosensitive. The sun doesn't seem to make a bit of a difference to him. And so there are some people where sun makes no difference whatsoever. How many people read the New York Times? A couple of people. Okay. In the Sunday Times a couple of weeks ago, they had a story in the business section, which is kind of odd. It was about this guy, Michael Hollick, who is he's an endocrinologist in Boston. He's a big proponent of vitamin D. So if you are maximally protecting yourself from sunlight, you need to take some vitamin D to replace it. And they were pointing out actually in that business article about how conflicted he was, because he's been supported by the people who manufacture the tests for vitamin D at levels, and he's been supported by the manufacturers of vitamin D, and he's been on a kick to, and then he thinks that you should be going out and getting some sun there, and he does it himself. And until he gets his skin cancer or melanoma, he'll probably continue to do that. Or if he develops a photosensitive disease, he might stop doing that. But every patient is slightly different in terms of photosensitivity, and that's been part of the problem. Even the patients who report photosensitivity, in other words, they go out in sunlight and they get the rash gets worse. People with experimental studies haven't been able to reproduce the rash, so we don't know what wavelength does it. Because the wavelengths of the sun, we see visible light, and then there's ultraviolet light. You've probably heard about this. Infrared light, which is different. the visible light, and then the ultraviolet light comes at A, B, and C. There's very little C that gets through the ozone surface. It protects us. If the C got through it, we would probably all be having skin cancers at very young ages. But B causes skin cancers, A causes more tanning. In lupus, both A and B seem to make the disease worse in most patients. And so sunscreens, when you read the label talks about SPF. That's the thing people talk about mostly. SPF 30, 50, 100, you know. That is the SPF is a protection factor, again, sun protection factor, SPF. And it measured against how much time it would take to develop a minimal burn with the sunscreen versus without the sunscreen. It's a ratio. Now, the problem is that you may think that a 60 is twice as good as a 30. Not true. 60 is about maybe 1 or 2% better than a 30. So, so for my patients, for all my patients, basically, I say 30 is fine. You know, if you can buy it at a 50 for the same price, it's fine. You know, anything more than a 30 to me is okay. But even better is the use of protective clothing and decent sense. You know, there's some, I don't remember if it's an old coward play or whatever, Mad Dogs and Englishmen go out in the midday sun. You know, don't go out in the midday sun. Over here, I'll get you to the next.
As soon as I go out in the sun, it feels like I have sunburn. As soon as the sun hits my body, I mean, I have clothing on, believe me, and a hat every day, but if I'm running to the store and say, only going from the garage and into the pool, but as soon as the sun hits my body, it feels like a sunburn right away. Is that kind of crazy?
No, I wouldn't say you're crazy.
I know.
I think there are some people who may feel that. I don't know. And so, you know, I'm a pragmatist. You know, if somebody says, you know, when I eat this food, it tastes bad, well, don't eat that food. You know. So if you can avoid what triggers it, then you should do.
I am, but there's times that you look at the mail and somebody starts talking to you and you're standing, and I take my mail and I stand up and you know, because I am, of course, I have my hair either on top, so I'm sure that.
So that's a good reason for you to wear a hat when you go to get your mail. Yeah, back. On the side, yeah.
So when you mentioned the sun sensitivity that I'm assuming we all have in some degree, does getting the sun on the skin, besides possibly aggravating or bringing out the rash more, does it also change like what's happening on the inside and aggravating the
we did mention it a little bit, maybe just before you came in the room, but that's no problem. So you know, the answer is there are patients where sunlight has exacerbated their muscle disease. I don't know of any patients where sunlight has either an exacerbating factor of lung disease or esophageal, dysmotility where you don't swallow as well, or joint aches necessarily. But it exacerbates the skin for sure. Sometimes it exacerbates muscle disease. That is, it is possible.
Thank you.
Yes.
You talked about the rash being symmetrical and predominantly above the waist. So if I have a rash that's on the back of my leg, growing on one leg, that's not near.
It'd be unlikely. Skin biopsies are very simple to do, and people could do that. And you may have eczema on your legs. That is little to do or nothing to do with your dermatomyositis. Somebody had something about.
Is there any difference in the skin involvement between juvenile dermatitis and myositis?
Okay, a slight yes and no. Okay, the rash is very similar, but children tend to get have a complication called calcinosis. Adults can have calcinosis, but it's rare.
So I was diagnosed when I was about 20 and acted a lot more like juvenile.
Okay, so right on the cusp. What is childhood? I had a patient who I see, and seeing her. She She was 18 when she was diagnosed, and she probably has some of the worst calcinosis that I've seen. And we treated her fairly aggressively, and she still has active skin disease, despite IVIG. And then
Yeah, the other thing is my rashes, I had really weird rashes that weren't itchy, weren't scaly or flaky. They were on the insides of my arms and the insides of my knees, and they looked like deep purple bruises. Any idea?
no, and I would have had to have seen it. We might have taken, might have taken a biopsy. It's not. I don't know. I mean,
Yeah.
I don't know if it's related, if it's true, or if it's unrelated. There are other things on this list. Let me talk a little bit about. So in the lecture, Dr. Mammon, was everybody in the lecture? The people who were, he was talking about myositis-specific antibodies. Have you all had those done? How many people?
Not the one with TIF.
TIF1.
We're
Yes.
supposed to be associated with.
TIF1 gamma. Yeah. So, okay, so let's just talk a little bit about that, because you may, if you go back to physicians, you may say, oh, maybe I should have this test done. I don't think it's real interesting for studies. There have been a lot of papers written about it. I think it's not really, and I've been saying this for probably 10 years, it's not ready for prime time. In the past, we had very few of these myositis-specific antibodies that were available to us. He talked about the progression, MI2 or MI2 named for the first patient, and he talked about the lab that developed it. We were able to get that, and it's probably a reliable test. The problem with that antibody, the MI2, is it's very specific for dermatomyositis. But only 25% of people who have dermatomyositis at best have that antibody. So I make the diagnosis clinically by looking at the skin, knowing that there's muscle disease associated with it or not, because you can have skin disease without muscle disease, and doing a biopsy and having that be compatible, and I've made the diagnosis. So why do I need to know whether you have MI2 or not? It rarely is helpful to me. If I was in a quandary and I said, does the patient have lupus or does the patient have dermatomyositis, and I still couldn't tell, because there are some instances that maybe if they had an MI2, it might be helpful in swaying me toward that's a diagnosis of dermatomyositis. The TIF1 gamma, in the study that he quoted, he said 58% of people had malignancy and 5% who don't have it have malignancy. So that means that there's 40% who don't have it, and I'm not sure that has been validated in a meaningful way. So 58% is just too high. So when the myositis-specific antibodies became available as a routine lab test, they're not done in your local labs. The local lab will send it. They usually send it to a laboratory called abbreviated ARUP, which is at the University of Utah. I'm not sure you told me you went to Cleveland Clinic. I don't know the Cleveland Clinic does that antibody test. They probably send it out. Yeah. So Oklahoma is one place. That's where Ira Tarboff, who's an investigator and has described some of these antibodies. They do it at Johns Hopkins, which is where Mammon is affiliated with. And the lab there is probably very reliable. The lab in Oklahoma is pretty reliable, but they're very slow and it takes a long time to get it. But the lab at the University of Utah, it takes anywhere between 2 to 4 weeks to get the answer back. But it's not clear how reliable it is. Some of the people who have been studying the antibodies aren't sure that the ELISA tests and the test kits that they use in Utah are fully reliable. So I started, when it became available, I started doing some testing, and I found maybe 3 or 4 patients, long-standing dermatomyositis, no malignancy, they had TIF1 gamma. Now what do I do? He said, well, we evaluate them more closely. But it's not a realistic, I don't know what to do with, I don't know what that means, evaluate somebody more closely.
Can I just interrupt that point right there? Because when I got diagnosed, that wasn't available to me. So the thinking, and I had a huge, workup immediately, and luckily for me, nothing happened. And then the thinking at that time was that you don't develop malignancies within 3 years of diagnosis.
That still is what I say at meetings. When you look at the data that has come out, that keeps accumulating, suggests that after 3 years, the probability of having an internal cancer goes down close to the background of what's normal in the population. So my stance when I have a patient and I make a diagnosis is that they have a malignancy evaluation. I'll explain what I do, whether it's right or wrong, I don't know. But I have a rationale for doing it. And then I have them repeat that every year for 3 years. And then we do what is ever, so a woman has a mammogram. Usually it's annually until you get to be age 70, and I think they stop doing it annually. You have a colonoscopy beginning at age 50 for every certain number of years, depending if you have polyps or you don't have polyps. And then I'm not sure if the GI Society has stopped wanting people to have colonoscopies or not. They haven't for me yet, so I don't know about the rest of the world. But and then pelvic exam and checking the ovaries, all those things should be done on an annual basis, assuming that you have a uterus and ovaries. If you don't have it, then pelvic exam is a good point. You're not going to get cancer in something you don't have. And there are women who have had, for various reasons, have had hysterectomy and had their ovaries removed. So when I see the patient, I'm generally, so when I make a diagnosis, as part of my initial workup, patients will have pulmonary function studies. They will have an esophageal study to see if they have any problems with swallowing. And then they'll have CT scans of the chest, abdomen, and pelvis. And a woman, what's that?
How often do you have it?
Okay, yearly for 3 years. And then after that, I don't do any of the CT scans anymore. Now, there was a study from Mexico that suggested we could replace everything that we do by doing a PET CT scan, it's whole body CT. But you get a lot more radiation from the PET CT. And there is a recent report that I reviewed, but it's not published yet, that suggested from a U.S. site that the PET CT might be something that we could replace the scans with. Okay. Now, so when you make the diagnosis, if you look in the literature, the literature varies, but maybe up to 20% of patients who have, it's 1 out of 5, we have dermatomyositis, have an associated malignancy. Sort of using associated in a very loose way. Okay? What that means is they have had a malignancy sometime in the past. They have a malignancy now when we make the diagnosis, or they're going to develop a malignancy sometime later. When we break it down, and we're looking for maybe about somewhere between 5 and 8%. So about 1 out of 20 to 1 out of 10. So 9 out of 10 times, when you look at the initial diagnosis, you're not going to find malignancy. And as you go year after year, the rate goes down. Okay? All right, let's say that we find a malignancy. What happens to the dermatomyositis? Okay, that's a question I'm going to pose and then the answer is what. So if we find a malignancy, and I have a number of patients where we have indeed found a malignancy, that malignancy has, we had one guy who, I'll tell you a story, we did the workup, they noted something on his CT scan of his abdomen, which was in his kidney. He saw urology, eventually he had his kidney taken out, and it made absolutely no difference to his dermatomyositis. Another man, I don't see him in the room here, but I saw him before I walked in the room. He probably went to a different session because he's heard everything that I had to say. But he came in, he had prostate cancer. At the time of diagnosis, he had prostate cancer effectively treated. He hasn't had any recurrence of prostate cancer, but his skin disease and his disease has marched on. On the other hand, there are some patients, but unfortunately it's the rare patient, who have had, it's good if we discover a malignancy, it's taken out, and then the disease goes away and it never comes back. unless the malignancy in some way comes back. That, to me, that what we call it a paraneoplastic course. In other words, they had the malignancy diagnosed, they had the myositis, and they ran together so that they took out the malignancy or treated it effectively. The dermatomyositis went away, malignancy comes back, the dermatomyositis comes back, and the like. The other thing, so I say that, now the only other caveat is one of the patients I saw today, she was totally clear of her dermatomyositis, removed from all her drugs, and about 5 years after that she came back with a rash again, itching rash, no muscle disease, doesn't feel well. And in that scenario, I usually will then repeat some malignancy evaluation at the time of re-diagnosis. I don't know if that's reasonable to do or not. You know, the data would suggest probably not, but I think when somebody has a flare, they need some additional, this is the way I handle it. Whether it's right or not, I don't know. But that's the way I handle it. So I'm going to do the malignancy evaluation coming back to the antibody study. I'm going to do it regardless of whether they have TIF1 gamma or not. If they don't have it, I'm still going to do that malignancy evaluation initially, because there are patients who have malignancy and don't have TIF1 gamma, and there are patients, maybe who have TIF1 gamma. There are a lot of patients who have TIF1 gamma and don't have malignancy. So that's why, to me, at this point in time, in 2018, the use of autoantibodies in the diagnosis is imperfect at best. And I tend not to, majority of the time, I probably tend not to do it. Somebody asked me about them, they're easy to get. They're usually covered by insurance, they're expensive, but you don't do them repeatedly because they're not tests that predict the course of the disease. In other words, the antibody, there are some, like a lupus related condition, an antibody called the anti-native DNA will go up when there's renal disease and go down when there's not. So that would predict the activity of the disease. With dermatomyositis, these myositis specific antibodies aren't correlated with the activity of the disease. And so for that reason, there's no reason to repeat them. And I'm not sure that there's a good reason to do it in the first place, because if you have a JO1, some of those patients, many of those patients have lung disease, but if you have dermatomyositis, the chance of having JO1 is really, really small. But I'm going to do your pulmonary function studies anyway, initially. Now, I don't repeat pulmonary function studies. My colleagues at the University of Pennsylvania, a woman named Vicki Worth, who I respect her, she has a different approach to it. She repeats pulmonary function studies annually. If patients are having problems with breathing, I'm going to do that. But if they have no problems with breathing, then I usually am not repeating an annual pulmonary function study.
10 years ago was when I had my diagnosis, and it was very acute, and my lungs were declined. They did everything, and then now 10 years later, it's starting to come back very slowly, and I tested positive for the JO1, and so they retested my lungs, and I was diagnosed with lung disease, and I don't have any problems breathing.
In somebody where the disease comes back, I probably would retest. It's an individual patient, though, an individual decision. I'm talking about generalities.
Just to follow up on what you were saying, I understand that you make diagnosis primarily on clinical findings and all that. My thinking, though, is, my question to you is, do you think it would be worthwhile leaving the autoantibodies as maybe not as foolproof as they are, more for correlating them at some point with response to medications? Because I know
it's a great question, and it would be a good idea if indeed we had knowledge that this antibody being present, that patient would respond to this medication. Medication X for X antibody, they don't match up yet. Not my thinking.
There was like a database put together.
There are ongoing studies of getting databases together. I'm talking about what would, if you're talking about a doctor that you're going to see in your local community who's going to care for you, is it useful for them to do the antibodies? And I would say no, not unless you're being part of the study. Somebody over here had a question. let's see what else I have here. So, okay. That's okay. All right, number 5. It's talking about treatment. It's on there. So I think the first line of treatment that people will reach for is corticosteroids, and they work great for muscle disease, and they work not all that well for skin disease. I don't know if has anybody had that experience where your steroids have helped your muscles, but the skin just keeps going regardless. So now I'm biased. I'm a dermatologist. People who don't have skin disease or who respond really well to whatever they're given come to see me. I've seen most of my patients, that has been the case, that steroids have had little long-term benefit. They also have problems. They change your appearance. You have a risk of osteoporosis. With osteoporosis, you have a risk of breaking bones. You have a risk of certain type of cataract. You have a risk of becoming a diabetic. I have made patients diabetic that weren't diabetic because of use of corticosteroids. I like to avoid it. High blood pressure is an issue at times because of fluid retention. And then there's a risk of infection. Now, with all the other drugs, most of the other drugs that we use to treat the skin that might suppress your immune system, there's a risk of infection. And I don't know if that's, I don't know if we can measure. Is it greater than steroids or is it less than steroids? But I can tell you that when we're used together and we start building cocktails of drugs that suppress your immune system, the risk is there. IVIG, on the other hand, there's really very little, if any, risk of infection. The risk is if they infuse it too quickly. You've had IVIG, and if they infuse it too quickly, you get a massive headache, don't you?
I had a brain aneurysm.
That's the problem. That's the real problem. They infuse it too quickly, and you have a lot of nurses who want to get in and get out of your house or wherever, and they want to infuse it as quickly as they can, and you can what's called thrombose. In other words, you clot the area, and then you can have hemorrhage from it. So if you're getting IVIG, make sure that you insist that they give it to you relatively slowly, or divide it up into 4 days instead of 2 days. You definitely don't want to take all the dose on 1 day. And the dose that we give, it's empiric. Nobody has. He mentioned this study that there in the talk. He mentioned this double-blind placebo-controlled trial that was done by Delacus. Its main outcome they were looking for was muscle disease, but they had a secondary outcome of skin disease, and it improved the skin disease. And so most everybody has taken that up. It's never had a formal trial like we would normally want, like they did with anybody participate in rituximab trials. You were in the trial. Did it work for you? You did get it because.
I got it.
Yeah.
The trial was supposed to be 2 months, and within the 2-month period, I felt nothing. The third month, or the end of the second into the third, awesome. But
For your skin or for your muscles?
for my everything,
For everything. Okay.
that was really good.
Yeah. You're starting rituximab. Okay. Okay.
I have just one question about lupus. Is that more or less common with 4 to half?
No, it doesn't make any difference which way you give it.
Okay.
If you're getting a large amount, having a port is something that's reasonable to do because people lose IV access when they're given too many injections peripherally. The Rituxan study, there were a lot of really smart people who were putting that together. I don't know why they put it together the way they did. It was called a double-blind placebo-controlled crossover trial. And what they did was they gave Rituxan for, I think, 4 weeks, weekly. I think they were giving it weekly. And then they waited 3 months, and they crossed the patient over to getting either the drug or the placebo. So there were half people got placebo first, and half people got placebo second. The mechanism of action for Rituxan, and he was talking about T cells. Rituxan doesn't have much effect on T cells at all. It has an effect on B cells. And it's not clear that dermatomyositis is a disease of B cells. So anyway, they gave it for 3 months, but when it does work, and I do use Rituxan, but not for dermatomyositis. I use it for a different condition called pemphigus. In that disease, the antibody it's been shown that the antibody that the patient has causes the disease. It's shown in really elegant studies in mouse models. But what happens in that disease, and any disease where Rituxan is effective, is that the antibodies disappear at about 3 to 6 months and then begin to reappear. So to give the drug for 3 months and then measure the response at 3 months, it was too soon. And then they flipped them over. And so the studies, and then they've been looking at what happened after the study and trying to reanalyze the data. But that's why rituximab would still be considered probably off-label. And it probably works for muscle disease maybe better than it does for skin disease. It's very spotty whether it works for skin disease. So if it's for your skin disease, I don't know. It wouldn't be something I would recommend. I have other things that I do. And I use a lot of drugs that suppress the immune system. He mentioned mycophenolate. Methotrexate is something we usually start with before we give mycophenolate. I think he mentioned azathioprine. I think azathioprine works for muscle disease, but I don't think it works very well for skin disease, dermatomyositis. I use it a lot for other diseases, but not generally for dermatomyositis. I use a drug called, and I don't use a lot of cyclosporin. It's a long-term use of cyclosporin, too many side effects. It's good in the short run. For the disease, it's approved for psoriasis, which is a common disease, and it works well for psoriasis. But in the short run, there's not so many side effects. But in the long run, if you give cyclosporin for a long enough period of time, and psoriasis is a chronic disease, you can't get the patients off of therapy. You give them cyclosporin, eventually they will have kidney failure because almost everybody will get an effect on the kidney. So I don't like giving cyclosporin for any length of time. So I don't use it because this is a chronic disease. I don't use it much in dermatomyositis. I will use a drug called coriandisol. It's also known as leucoran. Off-label. It's a disease which is approved for treating chronic lymphocytic leukemia. Which has nothing to do with dermatomyositis, but in some patients it works. It's something that we wrote our experience up. That was an open-label trial. Open-label trials are not what we want to base base our therapies on. But if that's all it's all that's available are anecdotes and small case series and things like that. So when I'm pushed IVIG, if I'm pushed beyond that for insurance reasons, and we have a bag full of things that we reach for and try to build a therapy. Now the newest thing I put on the bottom of that handout, cannabinoids. You know what a cannabinoid is? So it's related to marijuana, that's right. So Vicki Ward, who I mentioned earlier, who's at the University of Pennsylvania, has recently published a study about the use of the cannabinoid, and it's probably good for the itching, for sure. And it may also have some benefit. I emailed her after I saw it, read her study, and I emailed her and asked her about, well, did it help any of the signs of because she's developed a validated way of measuring the skin it's called a cutaneous dermatomyositis area and severity index, which we abbreviate by C-. I don't know if anybody's heard of that or anybody's measured that on you or anything like that. But it's for skin disease, we have all these things that are called ASI. It's an area and severity index. We use it for psoriasis, it's called PASI. We use it for eczema, it's called EASI. We use it in lupus, it's called CLASI, cutaneous lupus ASI. Dermatomyositis is called cutaneous dermatomyositis ASI. So in her study, in any study that she does, she will measure a C-DASI and has shown that the measurement of the activity seems to become less with the cannabinoid. I'm sure that we'll see there's only only one publication about the cannabinoid use at this point in time, and I think they are going to be available.
Is that oral or topical?
Oral, it's an oral meds.
Has anybody tried it topically?
Yeah, I don't know that it works much
It
topical.
doesn't work so much with the rash, but it works with the muscle and
You spoke earlier about lesions, and I don't know many DM patients who actually have what we would consider like a lesion version of the, not just rash, but an erosion of the dermal layer that's like a third-degree burn. And I got quite a few of those on my arms and some necrotic tissue, and they weren't able to give me anything for pain control. And I had a desperation by CBD oil, and was just interested if anybody had tried that topically, because I'm liking like a 15-minute solution.
Yeah.
That.
No, I don't know the answer.
It didn't.
It didn't?
CBD oil did not work for me. No, not topically. It did help with the muscle pain, I guess you could say, the muscle aching.
Yeah, so, okay, so it is, I have 5 after 5. What time is your dinner that you have to go to?
The buses start leaving at 5:30.
So, I mean, I'm happy to stay a few more minutes or answer any.
Hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources and much more that you can use, like info TMA compiles, and like lists of clinical trials and lists of research too. You can review because it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.